So we'll start our session by inviting Dr. Amit Pandya, our invited speaker. Dr. Ahmad Al-Isa, please proceed. Well, I would like to introduce Dr. Amit Pandya. I have a long list to say, but if I said all the list, I'm going to take the time of his presentation. Yes, of course, yes.
Nobody introduced the king.
Dr. Amit Pandya is the president of the Global Vitiligo Foundation and the ex-president of the SOX, the Skin of Color Society. And actually, Dr. Amit, I want to say something that I learned about you since I knew you, that you are a very scientific person, and at the same time you talk by as if you are the patient is always in your mind. And I really appreciate that, because you are the fighter for the patient, because you love your patients very much, you do a lot of work with them, and this is really reflected on all your work and your great effort for the research on vitiligo. So thank you, and please give us your presentation.
Thank you very much. Well, I appreciate that, and I appreciate the invitation to speak to you today in the VIS conference. Today I'll be talking about advances in the treatment of vitiligo with JAK inhibitors. JAK inhibitors are not a panacea. They are just one part of the overall treatment of vitiligo, but there's been some advances here lately, and I'm going to try to review those with you. These are my disclosures, and these are all companies that are developing products and phototherapy devices for vitiligo. So this is the most exciting time in my 30 years as a dermatologist when it comes to vitiligo. Well, we've seen many presentations about the pathogenesis of vitiligo. And this is a simple kind of a summary of what goes on. Interferon gamma seems to be involved very much so in the process of causing vitiligo. It binds with the interferon gamma receptor and the keratinocytes through the JAK-STAT pathway, produce CXCL9, CXCL10. It binds with the CXCR3 receptor of the T cell, which then kills the melanocyte. So it makes sense that you would want to use a JAK inhibitor to block this so that you will reduce CXCL9 and 10, and then the patient can improve. Well, these are what I call the 3 pillars of vitiligo treatment. I think in the future we'll have more, but overall this is how I see it. We want to reduce the triggers as the first pillar. We use antioxidants, and we've had many lectures on that. We also want to avoid trauma. I tell my patients to make sure they're wearing gloves to try to reduce trauma in whatever type of job or activity they're doing. The second thing is to reduce the immune attack on the skin. And we do this with corticosteroids, we do this with tacrolimus, pimecrolimus, and now we can do this with JAK inhibitors. This will specifically work on the T cell infiltrate in the skin that is killing the melanocyte. And then we want to increase melanocytes and melanin production in the skin. And phototherapy is the main way we do this. Unfortunately, we do not have afamelanotide. But I think that we need to find better ways of transplanting melanocytes to the skin. We use grafts. We are now using cellular grafting. And I think we need to come up with unique and innovative ways to get those melanocytes in areas that don't have any melanocytes. But one of my favorite immunosuppressive agents is phototherapy. After 3 months, phototherapy itself acts as an immunosuppressant in the skin. And it can allow you to have that bridge long term in keeping the T cells out of the skin. With these 3 pillars, you can finally achieve effective treatment of vitiligo. And so many patients come in only with 1 pillar or 2 pillars, but they are not doing all 3. So what are Janus kinase inhibitors? These are small molecules that are developed to treat immune-mediated diseases. They are tyrosine kinases that associate with cytokine receptors on cell surfaces. So here's this cytokine that you might be thinking, let's say this is interferon gamma. It binds with its receptor, and the JAK, oh, sorry, this battery just went out, but you can see the JAKs are heterodimers that are below it, and they phosphorylate. They phosphorylate, and then they phosphorylate the actual receptor, and then that causes the activation of the STAT path proteins, which then translocate to the nucleus, affect transcription, and what happens? Production of CXCL9 and 10, the signal that attracts the pathogenic T cell to the skin and causing destruction. There are 4 members of the JAK family: JAK1, JAK2, JAK3, and TYK2. So here we have some JAKs on the bottom and receptors. Suppose you wanted to treat rheumatoid arthritis or lupus. You know that IL-6 is important for these diseases. Therefore, you will choose a JAK inhibitor against 1, TYK2, JAK2, or a combination of those. Suppose you want to treat alopecia areata or vitiligo. You will pick, as you see, interferon is important in those diseases. You will pick a JAK inhibitor that affects JAK1, TYK2, or JAK2, as you see there. Suppose you want to treat myelofibrosis or polycythemia vera. You are going to want to affect EPO, erythropoietin. So you're going to pick a drug that's going to affect JAK2. Suppose you want to treat spondyloarthritis or psoriasis. You're going to want to block IL-12 and IL-23. So you're going to choose a JAK inhibitor that will affect JAK2 and TYK2. This is how these are selected for various diseases. Each JAK inhibitor has distinct selectivity across the family members to inhibit these cytokines, and it's been tailored, this development, to capitalize on these pathways. So you have them on the left, some of them that have been developed. You have what it inhibits, and notice that as time goes on, they become more selective, mainly for toxicity. Especially JAK2 inhibition can be toxic given systemically. But notice as time goes on, we are now getting to selective JAK inhibitors, JAK1 only, JAK3 only. As you can see, the diseases that are listed are the ones that are FDA approved. The ones that are in parentheses are the ones that are being studied but are not yet FDA approved. So you can see that many are being studied for vitiligo that are not yet FDA approved. Only Ruxolitinib is FDA approved for vitiligo. You can see, for example, Abrocitinib is approved for atopic dermatitis recently, and Ritlecitinib is being used in many different diseases but not approved yet. Now, when you give this to a patient, you have to think about adverse effects, oral JAK inhibitors. There's a small risk of increased cholesterol and cytopenias. There's also a small but statistically significant higher risk of opportunistic infections, tuberculosis, herpes zoster, but mainly in people on concomitant immunosuppressants. There was an oral surveillance study of tofacitinib oral versus TNF inhibitors for rheumatoid arthritis, in which they followed patients over the age of 50 with at least one cardiovascular risk factor. You need to know this when you are giving a patient tofacitinib, and I know in India, Cipla and other pharmaceuticals are selling this for $50 or less per month. This conversation you need to have with your patient. There's a small but significantly higher risk of myocardial infarction, stroke, thrombotic effects, lymphoma, lung cancer in smokers, and death in the tofacitinib group. The black box warning was required by the FDA in September 2021 for tofacitinib. They also extended it to upadacitinib and baricitinib, even though the data is not there because of its mechanism of action. But the risk of side effects is very low in patients who are less than 50 years of age and those without cardiovascular risk factors. In the hundreds of patients that have been treated for alopecia areata and vitiligo, we are just not seeing that. It must be very low. I'm sure it's there, but it must be very low. So you need to reduce the dose if a patient has renal or hepatic impairment, or they're on fluconazole or ketoconazole. And you can see the blood testing that we do. This is the recommended blood testing at baseline, and then you repeat that after 1 month and every 3 months, and do a tuberculosis screening annually. So there have been some JAK inhibitors used specifically for vitiligo, and I'm listing these up here. We already have results for the first 4 bullet points. You will be seeing the results for the last 2 coming up in March at the AAD meeting. The results for the phase 2 studies will be presented there. So Brett King published this in 2015, a patient with vitiligo who was given oral tofacitinib, 5 milligrams every other day, and then 5 milligrams per day, and she had good results, and she had no side effects. He went on with this 35-year-old woman with vitiligo for 12 years. She was given the 5 milligrams twice a day, which is more typical dose, and narrowband UVB twice a week, and she had very good repigmentation. Now, the cost of 60 pills of tofacitinib is typically $4,200 for the brand name, but now it's available generically in India for $50 for 60 pills. So I know many of you are already using it, and I'm hoping that we will be seeing data, large numbers of patients with data on vitiligo coming from countries like yours. This study showed that repigmentation with oral terbinafine may require concomitant light exposure. You can see here after treatment, this woman's chest improved, but the area under her breast did not. So the JAK inhibitors are not a panacea just by themselves. They really require some type of stimulation of melanocyte production. And indeed, in this study out of China, 15 patients were treated with tofacitinib and UVB, and the other 19 were only treated with UVB. All of them got topicals. And look at the red line. There was significant improvement in the VASI, almost to zero in the patients who got the combination treatment rather than the treatment with the narrowband UVB alone. So UVB plus tofacitinib was better than UVB alone. We tried 2% compounded tofacitinib cream in 11 patients, and we had a mean VASI improvement of 70% on the face. And these patients were unresponsive to narrowband UVB or topical steroids or tacrolimus. You can see the VASI improvement was 70%. Here's a patient with improvement after 4 months. You can see here that on their other side of the cheek. Here's a patient with improvement after 4 months. And these are patients who were not responding to topicals and narrowband UVB by themselves. That includes tacrolimus or steroids. Here's a patient with mixed vitiligo, segmental on the left side of her face and non-segmental on the rest of her face. You can see how she improved in 3 months. So this is something that hopefully generic companies will start making, topical tofacitinib, 2%, that could be an option for patients with limited disease. Topical ruxolitinib was first published in 2017, in which Dr. Rosmarin and colleagues treated 9 patients, and they had excellent results in 4 patients with facial involvement, and they had only 23% improvement in patients on the body. And so they said UV exposure is likely necessary, so a phase 2 study was completed. This phase 2 study had 157 patients with 0.5% facial involvement, more than 3% non-facial involvement, and they looked at how many patients got an F-VASI 50. F-VASI 50 means that 50% of your color came back on your face. T-VASI 50 means 50% of the color came back on your body. And if you look at the study, you can see the first 24 weeks, there were 4 different dosing regimens, and then the last part of the 28 weeks, the last part of the year, they were switched to the 3 higher dosing regimens, 0.5, 1.5, once a day, and 1.5 twice a day. And let's see here. There we go. So these patients were 18 to 75 years of age. And so the question about children is going to come up in a minute. These patients were average 48 years old. The 84% were white. Very few Hindustanis in this particular study. You can see the majority were types 1, 2, and 3. You can see the baseline F-VASI was 1.26. That's a lot of involvement. The hand is 1%. These people had more than the size of a hand on their face. They had 18% on the total body. Duration of disease was 14 years. So these were very difficult to treat patients. And you can see that after 24 weeks, 50% of the patients, 45 to 50%, had half the color back on their face. But notice that even after 1 year, that only increased a little bit. When you looked at the patients who got 75% of the color back on their face, you can see 50% did after 52 weeks. So the F-VASI 75 was definitely improved after 52 weeks compared to 24 weeks. And you can see the 90 on the right. Now in this, when you look at the T-VASI, these patients were not allowed to apply the cream to more than 20% of their body. Why? Because Ruxolitinib is a JAK2 inhibitor, which affects the bone marrow. If you apply it to too much of your body, your hemoglobin can go down. So these patients were only allowed to apply it to 20% or less. If we look at that group, you can see that the T-VASI 50 after 1 year was 45%. So I tell my patients, if you use this for 1 year, you have your average improvement will be 50% on your body, 45, 50% on your body. Here's an example of a patient who improved dramatically on the face after 6 months. This is one of my patients who was on placebo for 6 months. Then she went on active disease once a day, and she had 93% improvement, and she was getting sun exposure in Dallas, Texas. Here's the elbow you can see after 1 year. And in terms of side effects, it was mainly acne. We saw acne in about 10% of patients, which did not cause them to stop the treatment. So the summary was that there was substantial repigmentation, continued improvement throughout 52 weeks, and longer duration gave more repigmentation. All doses were well tolerated. So this article just came out in the New England Journal of Medicine, and that's the phase 3 study that allowed the FDA to approve this. In this case, we only used the highest dose, 1.5% Ruxolitinib twice a day for 6 months, followed by the open label. They were all treated for the last half of the year. Now these were children 12 years to 18 years that were also included in this study. So the FDA approval is for children, for people 12 years of age or over, but Insight will be doing the study in younger children very soon. In terms of important things to look at, these are older patients, 38, 40. You can see 80 to 83% were white. You can see skin types were mainly types 2 and 3. If you look, they were mainly from North America and Europe. As you can see that Europe also had about 30% of the patients. You can see that the F-VASI was about 0.52, 0.59, and the T-VASI was 6.5. So still significant amount of disease. You can see the BSAs are right there. The duration of the disease was 13 years and 15 years. Difficult to treat patients. And when you look at the progressive disease, active disease, you can see that 25% had active disease. So when you look at the results, you can see they were very similar to the phase 2 study. These are almost exactly the same. You can see the F-VASI 75, 52% in one study, 48% in the other study after 52 weeks. You can see the F-VASI 50 response, 75% over here in the extension, and the 74% in that one. You can see in the treatment extension, I'm sorry, that slide didn't come out, but this is T-VASI. You can see the improvement in the T-VASI there. And here's an example of a patient who did improve dramatically from an F-VASI of 1 to F-VASI of 0.01 over 1 year. And here you see the knees where there are follicles, and even the antecubital fossa where there was improvement. In terms of side effects, again, acne was seen in 5.9 and 5.7 patients, and then application site pruritus in 5% in both studies. It's a very well-tolerated cream. Patients like it. They don't have any complaints about this cream. So the summary is that there were significant facial and total body repigmentation, continued improvement through 52 weeks, longer duration is associated with greater repigmentation, near complete facial repigmentation was achieved, and it was approved on July 18th for vitiligo, the first drug in history approved for vitiligo by the FDA. And we're hoping this will be the first of many in the future. So we did a smaller look at a group of 19 of these patients who then did narrowband UVB 3 times a week. And you can see in the green that after completing 52 weeks of Ruxolitinib cream, if you add narrowband UVB, you will get an increase in the efficacy. These patients, keep in mind, were not on narrowband UVB during the 52 week of the treatment. And you can see it all improved. The African-American patient is my patient, and he was not satisfied there at week 52. and he was very delighted when phototherapy was given to him as a machine in his house by the company that did the study, and he treated himself 3 times a week. Look at him 1 year later. Imagine how delighted he was with his face and his body repigmented like that with a combination of Ruxolitinib cream and phototherapy. Okay, let me go on to oral Ritlecitinib, because this was recently published in the JAD. This is a highly selective JAK3 and TEC kinase inhibitor. 364 patients treated for 24 weeks with 24-week extension period. It was a dose-ranging study with 5 dosing groups and a placebo group. Inclusion criteria were total body surface area of 4 to 50%, facial of over 0.25%, and this is very important. This study required at least 1 active lesion. It did not enroll stable patients. The primary endpoint was the percent change in baseline at week 24 in centrally read F-VASI at 24 weeks. What does centrally read mean? It means a group of 3 dermatologists looked at pictures and determined the improvement as the primary efficacy variable. Not the investigator, but the 3 dermatologists who looked at the pictures. So it was more uniform and consistent. The secondary endpoint was F-VASI 75. And you can see the 5 groups followed by placebo. Do you see the little 200 and the 100? Those are loading doses for 1 month, followed by maintenance doses. So you can see there were loading doses on two groups, and then the extension period was loading doses on all groups, followed by Ritlecitinib 50 milligrams a day. And here you see the ones that got F-VASI 75. Now, one of our individuals with vitiligo said that patients are not satisfied unless they have 100% repigmentation, because even if there's a small spot, people say you have vitiligo. Well, we did a study in the United States, and we found that patients, when they were shown pictures, they said that 80%, 75 to 80% was enough to allow them to continue with treatment, and they saw that as a measure of success. So I think F-VASI 75 is a reasonable measure of success. And you can see that after this study was over at 24 weeks, 12% of the patients achieved F-VASI 75. It was not too high. However, let's see here. I think part of my slide got cut off, unfortunately. And so what was found, however, is that from 24 to 48 weeks, there was a very substantial drop in the F-VASI, in the patients who in their F-VASI, to the point where it was the majority of the patients had a 60% improvement in their F-VASI. So extending the treatment for 6 months really seemed to make a difference. And it may be because for active vitiligo, first you need to get rid of the T cells, then and only then will it improve. Whereas in the Ruxolitinib study, we already had stable patients who started to improve faster. And so I think that in the future studies, they're going to be enrolling patients with both stable and active vitiligo. And here you can see represented photos from both light and dark skin types in these patients. So the results were the change from baseline in local red T-VASI was from -12 to -19 at 24 weeks, but it was -60 to -66 at 48 weeks. That is excellent. And the proportion of centrally read F-VASI 75 went from 30 to 37%. Similar rates of infections, no dose-depending trends in adverse events, no clinical meaningful trends in hematology or chemistry lab results were seen. So that's exciting that this oral drug really seemed to be safe during this study. So it seemed to be effective and well tolerated. Longer treatment duration may be required, and I think the future study, the phase 3 study that's going to be starting here soon or already started, will include patients with both stable and active vitiligo. So, perfect timing. So to summarize, I think JAK TYK2 inhibitors inhibit pathogenic T cells that target melanocytes, and they show promise in the treatment of vitiligo. However, treatment is likely optimized when you combine it with UV light exposure or at least sunlight exposure. And multiple studies are underway to determine the optimal inhibitor, the method of delivery, the dosing, and the use in combination therapy. And I just want to finish with an acknowledgement. Dr. Hamzavi talked about fact that in order to have success in vitiligo, we have to have a community. I have been supported by this incredible community during my career. As I have worked on vitiligo, I am simply working with this huge group, and because of them, I've been able to be involved with many of these advances in vitiligo. So I thank all of the ones up here, and especially our patients who you can see here are people with vitiligo, are individuals with vitiligo we are always thinking about as we work really hard to find a cure for this disease. I'll stop there, and I thank you for your attention.
Well, thank you very much, Amit. And does anyone have a question for Dr. Pandya?
I have a question, if you don't mind.
Yes.
Yes, thank you. Good talk, as usual. Whenever I go to any conference, vitiligo, my patients waiting for me. What's new? What's new? So for the last 2 years, we've been talking about the biological and the JAK inhibitors. So when the first cream comes, the JAK inhibitor, Ritlecitinib, they were a little bit disappointed. Why? One, too expensive. Second, works only in the face, or mainly on the face, which tacrolimus and eczema does fantastic job, almost 100%. We never had any problem. We never had any problem with the face. So my question, when gonna we see it cheaper, and when gonna see something non-facial? This is what all our patients waiting for.
Right. So yeah, the expense is definitely a huge problem for all of us. This cream is $2,000 for a tube. It's unbelievable. Fortunately, at least in the United States, many insurance companies are covering it, so patients only pay $10 for the cream. It doesn't burn on the eyelids like some people have with tacrolimus. It is completely safe on the eyelids, the mouth, the genitals in terms of safety compared to steroids. It does work well in areas with black hairs, even on below the neck. And so when you talk about the T-VASI, this includes the elbows, the knees, the wrists, etc. However, I have seen excellent results on the proximal extremities, on the forearms, on the knees, on the thighs, on the posterior thighs, on the abdomen, on the flanks, on the buttocks. I have seen excellent results there. So I think the T-VASI, unfortunately, can be skewed because there's so much in those areas. But you're right. I think that all this is doing is removing the T cells from the skin. It is not adding melanocytes. And the other problem is that all these studies were done without any phototherapy. These patients, the reason their face got better is because they were covered. They were patients from Boston, from Chicago. The ones in Dallas were trying to get some sun, and they got some improvement. But I think in the future, we just finished enrolling our last patient in the combination narrowband UVB and Ruxolitinib study. And so that's going to be a 1-year study. So hopefully in 1 year, you'll see the results for that one.
Thank you very much, sir, for that interesting talk. I had 2 doubts. One is in the Ruxolitinib study. How did you dose the topical cream, for example, to use on the face? Was it the same way like how 1 fingertip unit of steroids is used, a similar way of dosing you used for spreading the cream?
Yes. One pea-sized amount on the tip of the finger applied to the areas, and then apply it to the areas to include 1 centimeter of normal skin in the periphery of the vitiligo lesion. Okay. So just a small amount, and it has to be worked in until it disappears.
Okay, so the pea size must be standardized, no, sir? So what would have been the concentration of the drug in that? Like, for example,
the concentration was 1.5%.
For the pea size?
But it,
in that pea size?
No, because keep in mind that some of these patients only had a small amount of vitiligo. So they would be using half a pea size. Some people had the entire face. They would be using 3 pea size, you see?
Yes, yes.
So it really depends on the extent.
Okay, sir. No, that's what I had to think. So, like, for example, it has been standardized now for topical steroids. Like, for example, the whole face, 1 fingertip is more than enough to apply. So maybe we might have to standardize later once we get for the thing. Right. And second one was, the chairperson already asked, like, why can't tacrolimus be a poor man's thing instead of Ruxolitinib?
But some people don't like tacrolimus. And also keep in mind that tofacitinib is also one that is now generic. And so I think that we should look forward especially in developing countries and people who cannot afford, we should be looking forward to JAK inhibitors that have lost their patent, who are now the generic manufacturing of some of these topicals, to see that for patients who cannot afford these really expensive.
So maybe we can ask them to have some amount of sun exposure also, no? So like for example, yesterday when I summarized also, most of the studies have showed more than 50% improvement in all sun exposed areas. So maybe you can ask the patients to have some amount of sun exposure, around 15 to 20 minutes daily.
That's exactly what I do in my practice.
Yes, sir.
Or I put them on phototherapy. However, keep in mind for an FDA study, how would it look if we told the patients in the protocol, we want all patients to get
not for the study per se, sir, for the patient per se when they come for the
That's why
treatment.
in the study, we could not say that.
Yes, thank you, sir.
So we have only 2 more questions, Dr. Laila, and there's a doctor there. Dr. Laila.
Thank you so much, Amit, for this excellent presentation. I would like to know what was the follow-up of your patients, and is there any relapse, and if there any relapse about...
Well, first of all, follow-up, the follow-up study we have is 3 years, 156 weeks, in which we continue to treat the patients with Ruxolitinib. And we found that after 1 year, they not only maintained their improvement, but they continued to improve for the 2 extra years. What we have not done is taken a look at people who stopped the treatment and look at them 6 months, 12 months. I have a feeling it's going to be similar to what we see with other topicals, that eventually 40% of patients after 1 or 2 years will have some relapse.
I want to ask one question. After the Ruxolitinib was approved, we have hundreds of questions from our patients. And I just put, when should I prescribe Ruxolitinib? Well, I put an idea that if it is a localized lesion which is not responding to topical calcineurin inhibitors. But I mean, do you have other suggestions? Usually the patient with their fingers with no pigmentation, those with the elbows, the resistant sites, when they heard about it, they come and ask. So I say, no, it will not do more better.
You have to manage their expectations.
Yes.
It's kind of like lasers for melasma.
Yes.
People think that, I have melasma, laser's going to take... You have to manage people's expectations, and you have to say, here's the reality with this drug. You know, every drug has its own place, and unfortunately people think that it's a panacea.
All right, thank you. Thank you, Dr. Pandya.